Hi, everyone. My name is Betsy Dovec, and I am the host of What's Up, Dr. Dovec. And today we have a topic that is very interesting to me, and that is very intimately involved with what we do as a bariatric surgery practice, and that is sleep medicine. Sleep medicine and sleep disorders can include things from insomnia to restless leg to obstructive sleep apnea, which I know a few things about. And today we're going to bring on Dr. Stephanie Wappel, who is a sleep specialist here at GBMC Hospital. So Stephanie, welcome to our show.
Thank you very much. Thank you for having me.
Oh, well, awesome. We have a lot to talk about. A lot of people have issues with their sleep, and I actually can't wait to know what you consider to be, the right amount of sleep and when we should sleep and sleep hygiene, because I know that those things are also so important in losing weight. Some people think they're hungry at night, they're eating when really they're tired, go to sleep. So before we even get started on all the disorders, I gotta know, how many hours of sleep should we ideally have a night?
So, outside of the extremes, which are kind of outliers of long sleepers or short sleepers, the average adult needs 7 to 8 hours of sleep per night or per day if they work shift work. Ideally, that's all continuous sleep, but 7 to 8 hours is kind of the magic time.
Perfect. Okay. Well, that's good to know. So everybody, you heard it here first, 7, 8 hours. All right. So let's get into the different issues that can occur with your sleep. So I want to specifically start and talk about obstructive sleep apnea. So somebody might come in and say, yeah, I snore, but it's no big deal. I feel okay. So how do they even get started with that diagnosis? How do we go from there?
So those tend to be the more challenging cases if their only complaint is that a bed partner or a roommate told them that they snore loudly. But usually I get into a lot more details to figure out what exactly is going on with their sleep. Are they having frequent awakenings during the night? Are they sleepy during the day? Are they waking up gasping for air? And then we kind of go from there as to whether this is sleep apnea or something else or primary snoring.
So is there any type of screening tool if someone's at home right now and they don't have a sleep partner, they don't have a roommate, they don't really know, they do feel exhausted, they have migraines, they think they might have it, they think they sometimes kind of hear themselves snoring almost or gasping for air. What is a good screening tool that they can do right now to see if they should be screened for sleep apnea?
Sure. So one that we commonly use that was developed by an anesthesiologist for preoperative screening for obstructive sleep apnea is called the Stop Bang score. So it takes into account 8 different factors, and it's much more objective than some of the other screening tools. So the S stands for snoring. Are you a loud snorer? Do you snore loudly? The T stands for tired. Are you tired or sleepy during the day? The O is for observed. Has anyone observed pauses in your breathing during sleep? The P is for pressure, high blood pressure. Do you have a diagnosis of high blood pressure? The B is for BMI, so a body mass index over 35, which would be class 2 obesity. The A is for age, so age over 50. The N is for neck circumference, which is greater than 17 inches for men or 16 inches for women, is a risk factor for sleep apnea. And finally, the G is for gender, because men are at higher risk of obstructive sleep apnea compared to premenopausal women. So I usually give a little asterisk if it's a postmenopausal woman, because that kind of gives them a point in my book, although it's not exactly in the score.
Wow. I asked her before we went live, I'm like, can you rattle off the whole stop bang? Because I've tried to memorize it. I mean, Dr. Wappel here, she's already impressing me. So if you wanted to check that out again, it's called Stop Bang, STOPBANG. It all stands for something you should check out to see if you're at risk. So let's say someone has a score, it's greater than 6. It's a man who has high blood pressure, BMI of 43. They fit the neck circumference, the size, the whole thing. They have all of it. So how do they find out if they have sleep apnea?
Sure. No, great question. So a score of 3 or more would indicate at least a moderate risk. But what you pointed out with a score of 6 out of 8 is a high risk, high clinical suspicion for having obstructive sleep apnea. So they could discuss with their primary care or another specialist. So we get a lot of referrals from the bariatric surgery practice and also from our ENT surgeons, or they can come to sleep clinic for evaluation. But if they talk to another doctor outside of our sleep practice, they can have have either a home sleep test or an in-lab sleep study ordered to actually determine if they have the diagnosis.
So there's another scale, it's called the Epworth Sleepiness Scale, and this is where it is subjective, and it's something we've done for the last 10 years, which I know we need to transition to stop bang. So if I have a patient whose score on these subjective criteria, how likely you're to fall asleep, it's greater than 10, I do refer every single one of my patients. It's nothing personal, but for patients out there, they're like, oh, I don't want to do it. I'm like, no, listen, it's not bad because you just mentioned it. You can do a home sleep study. So how does that, I should know this, but I know it's simple. I've heard that. How does it arrive and what does a patient do with this thing when it comes to their door?
Yeah, no, that's a good point. I do just want to say that you're not wrong, certainly in using the Epworth score. Excessive sleepiness, did it freeze for me here? Excessive sleepiness in obstructive sleep apnea does seem to be a higher risk factor for cardiovascular disease. So the home sleep test, there's different types of devices. We had to switch to a disposable device that was kind of a different technology than we usually use, but with COVID, we've now gone back to our traditional home sleep study device, which is mailed to the patient. They wear it for 2 nights and then mail it back. It has a nasal cannula that they wear to measure their airflow. There's a band around the chest that is measuring respiratory effort. There's a little position sensor and a microphone so we can see what position they're sleeping in, as well as if they're snoring. And then there's also a pulse ox monitor on their finger, which is measuring their oxygen level throughout the night, as well as their heart rate.
Wow. I did not know that, to be honest. I thought it was, I said, I think you put something on your forehead. I was completely wrong. So to all my patients out there, I know, all the times, I've said it hundreds of times that was just something minor, but it is minor. And it's so great because people always will say, with all due respect, that they don't want to spend the night in a sleep center, especially with COVID. But if, let's say, a patient absolutely needs to go into that sleep center for whatever reason, are they open now or are they still closed with all the COVID precautions?
Yes, great question again. So we did close our sleep lab based on American Academy of Sleep Medicine recommendations from mid-March to mid-June. We had a lot of meetings and discussions about the safe way to reopen, and we are now open not at full capacity, but almost at full capacity, doing sleep studies Monday through Friday nights instead of weekends as well. We are using extra precautions. Everyone has their own room in the sleep lab, in the sleep lab anyway. So they had their own bedroom, their own bathroom, all of that. And we're trying to limit our Cpap titration studies or any machines that they would be using overnight unless there's a clear indication. So those tests are ordered specifically from one of the sleep physicians in our practice. But other in-lab sleep studies are being done for diagnostic purposes now. So we're happy to have it reopened.
That's great. But it's great to also hear that the majority can be done in your own homes. You just wear it, you go to sleep, 2 nights, wake up, mail it back, and that's it. And let's say, you guys do an amazing job. And I shouldn't say you guys, it's all women. You guys have some lady bosses in that clinic. I love the GBMC Sleep Center. By the way, I had that number on memorized. Look at me. I'm not looking down. 443-849-3901. I must type it 15 times a day. I always do because you guys just take such excellent care of our patients. It's such a great collaboration. But let's say they do get the either in-person, in-house or home sleep study. It comes back that they have a diagnosis of sleep apnea. Tell me about the different levels of severity and then the different treatment that you would prescribe based on that.
Sure. So if we're talking exclusively about obstructive sleep apnea, when the upper airway is collapsing during sleep, what we look at to determine the severity is actually what we call the Apnea Hypopnea Index, or AHI. So our fancy medical term for the number of times per hour of sleep that the upper airway is completely or partially collapsing. So the hypopneas are partial collapse. So if there are at least 5 events per hour of sleep, that's considered abnormal and diagnostic of obstructive sleep apnea. Between 5 and 15 is considered moderate. Between 15 and 30 is, between 5 and 15 is mild. Between 15 and 30 is moderate, and greater than 30 events per hour is considered severe. I do always explain to my patients that the severity is being defined purely by the number of times per hour that their upper airway is closing. I have seen patients who have mild obstructive sleep apnea who have very severe symptoms and do really, really well in responding to treatment. And I have some patients who have severe sleep apnea by the numbers and actually are minimally asymptomatic. So there's a lot more to sleep apnea than meets the eye. It's not a one-size-fits-all sleep disorder, but we do have different treatment options depending on the severity. That is typically how we guide our treatment. And the hope in the future is that there's a lot of research going into different categories of people with obstructive sleep apnea and who's going to benefit the most from each treatment. Cpap is our first line. It's our most effective overall for most patients with obstructive sleep apnea, especially if they're symptomatic. So it's a machine connected to a tube to a mask. Mask is worn either under the nose or around the nose or around the nose and mouth, and it's delivering continuous positive airway pressure. So with obstructive sleep apnea, the upper airway is closing during sleep, so we need to keep it open. So this machine delivers the pressure that the patient needs to keep their upper airway open and prevent it from collapsing. We do also have, there's an oral appliance that's a specialized mouth guard that actually helps move the jaw slightly forward and down while the patient is sleeping, and that helps bring the tongue forward and keep the upper airway open. And then there are also several different surgical options to open up the upper airway or clear out the nasal passages and make more room for the patient to breathe during sleep.
Yeah, in all seriousness, I get patients all the time and they'll say, oh, I have moderate sleep apnea or I have severe sleep apnea. I've seen their airway closing off, that AHI so high sometimes. And it's just frightening because patients, you could die in your sleep. You hear the stories of it's just terrifying sometimes. When you see those results, I'm like, you need to get there immediately and you need to get treatment as fast as you can because this is just scary, as you mentioned. And some people then will say, oh, I can't take it. It's suffocating. I just feel like I'm drowning. And I know that you guys is absolutely exceptional at working with them individually and finding the right option for them. So tell me a little bit about more about what do you think the most comfortable one is? Is it the nasal pillow that you have? Would you say that that's the most comfort for what you got going on there?
Another great question, a challenging one. These questions have layers and layers, but I think, honestly, it's just really working with the patient and figuring out what's going to be best for them. There's a lot of new mask designs within the kind of 4 main types that I think of: the pillow that sits under the nose, the nasal mask, the hybrid full face that goes under the nose and around the mouth, and then the full face mask. So there's 4 main kind of designs now, and within them there's different models made by different companies. So there's actually some of the companies now are like Philips Respironics is one of the main companies that makes Cpap and Cpap masks, and they actually have a new 3D mask fitter. I think it's an app that basically takes the patient's picture and face and tries to figure out the best mask fit for them. So it's been a little bit more trial and error with COVID because we're not having the companies do in-person mask fitting. So I typically recommend, if I think the person has more mild, moderate sleep apnea and they're really hesitant about starting on Cpap, then I usually say, let's start with a nasal pillow and see how things go. If it's really severe sleep apnea, they may need high pressure and they may just do better getting that air through the nose and mouth with a full face mask.
That's interesting. I would love to invest in this company that can take a picture of the face and then find this right mask. I mean, my goodness, because I think a lot of people would, because there are, as we know, there's some occupations out there, like, for example, the Maryland Transit Authority, the Department of Transportation, that require that patients with a certain neck circumference on physical exam every year, every 2 years, whatever their screening is, be screened for sleep apnea. And sometimes I get patients who say, I want bariatric surgery because I have sleep apnea and I don't want to wear the mask or I'm scared of it or what have you. So you work very closely with, I'm sure, the DOT a lot. You probably see a lot of those patients.
Yes, we do.
So more about the treatment for this. So I'll just tell you, for bariatric surgery, we require that patients, of course, be screened. So we determine whether or not we should do the test, and we do a home sleep study on the majority of our patients. They'll have the home sleep study. If that's not adequate, they'll go for an in-person sleep study. If they have mild sleep apnea, we do still want them to talk to the GBMC Sleep Center, talk to Dr. Wappel and her colleagues and say, do you think that they need Cpap? If they have moderate sleep apnea, we do require that our patients demonstrate Cpap compliance. So that means they need to wear the Cpap machine at least 4 hours, at least 50% of the time. That's defined as compliance. If not, we try you go back, keep trying, get with the companies, do whatever you can to find the right mask, the right fit, so that you'll keep that machine on. And then finally, severe sleep apnea, we absolutely require Cpap compliance, and we do not do those procedures at an outpatient surgery center. So what's the point of doing all these things? Well, I'll tell you that you help us to get these patients safely through surgery. And then let's say they come back to you, they've lost 100 pounds, 200 pounds, their BMI is now 23, 24. What happens to their sleep apnea then?
So that is also a great question. So it's really, it's very rewarding to kind of see people through this journey and through their weight loss journey in particular, because when they first come in, we talk to them about the different factors that are probably contributing to why that person has obstructive sleep apnea. In some cases, a patient I saw earlier today, it may actually be completely driven by their weight. They just have more a very crowded upper airway now, large neck, and they just can't get enough. They don't have enough room when they're sleeping and all their muscles relax. If there's a lot of other factors coming in, like anatomical factors, then weight loss may not be completely curative, but in a lot of ways, significant weight loss, like what you just described, like what we can see with people undergoing weight loss surgery, it can lead to near or complete resolution of their obstructive sleep apnea. So I tell patients, I'm relatively new in practice, so right now I haven't seen many who have come on the other side yet. They're just starting to, because I just started last year, but I'm telling them to schedule an appointment with me maybe 2 months after their surgery so we can start to track their weight loss. And I keep them in an auto-adjusting Cpap mode for now, because with anticipation that they're going to need less pressure as they start to lose weight. And then once we think they're kind of at or near their goal weight and they're feeling like their sleep is much better, we can repeat the sleep study, and I'm happy to take them off Cpap if they no longer need it.
That is so exciting when they come back in and they no longer need the Cpap machines. Now, I will say that on the other side of it, some people have fallen in love with their Cpap machines. You know this to be true. Some people are like, they fight it, they don't want it, nobody wants to wear this Darth Vader thing, whatever. I've heard it, I'm sure you've heard even more. And then they ultimately start wearing it and they're like, my gosh, I don't have a migraine. I feel so rested. My own father is one that I did the old Epworth on him, and then we did a sleep study, and I think you read it. And he's been wearing it, and he's been doing fabulous. Now they lose weight, and then they don't want to give up. Some people are like, it's like my blankie, I got to sleep with it. So is there a detriment if they no longer have sleep apnea, but they just need it for the white noise? They just keep wanting to wear it. Can they keep wearing it?
I have not seen that yet. I feel like most likely if they still feel like they need it, then it's probably they maybe have a little bit of mild sleep apnea. So they may have gone from like an apnea-hypopnea index of like 60 down to maybe 12. And so it's mild sleep apnea now, or maybe it's even 8, but it's still a little bit, and they may just feel much more comfortable breathing with Cpap. Most likely it's a much lower pressure than what they were on when their weight was higher and they had more severe sleep apnea. But some people are very pleasantly surprised with how they feel after sleeping with Cpap and things they didn't expect. So sometimes it's the opposite. They expect a life-changing thing in one night, and it takes a little longer than that to adjust or realize how they're actually, what's actually improving with it. But Yeah.
I see it both ways as well. I see it a lot. People beg me to just make an exception, push them through, and we just won't do it. We just want the safety. It's all about safely getting patients through and treating these chronic conditions. But it is rewarding stuff, and I'm curious, how did you get into sleep medicine as your career choice? How does one do that?
I know I don't know if I even have a very clear answer for it, but I'm so happy I found this field. It's definitely my calling. I always loved internal medicine. That was my, trade. I did residency in internal medicine. I like looking at every system, and trying to figure out how everything ties together. And that's sort of what attracted me to pulmonary medicine and critical care, because you do continue to get to look at all the systems. And someone told me once, we inhale the world. So everything we breathe in can cause different diseases and different things that people present with pulmonary disease. And there's a lot of overlap with sleep medicine. So traditionally, a lot of sleep physicians were pulmonary critical care trained. It is sleep medicine is about 10% of the pulmonary boards, but now you have to do a separate sleep fellowship. So I found that sleep medicine allowed me to combine my interest in pulmonary medicine, my interest in respiratory physiology and ventilators, and the positive airway pressure, but also I get to address things like insomnia, mental health, different heart conditions to some degree, because there's some heart failure and sleep disorders associated with heart failure. So it's been very rewarding. Long path. I don't know how I would have chosen, how I would have figured out how to get here. It just happened, but I'm very happy to be here.
Yeah, speaking of, hey, out there, if you're maybe in high school, you're just starting med school, whatever, you think, I want to do this. It took Dr. Wappel 8 years to become a sleep specialist. She was largely at some very prestigious universities across the country, including Georgetown and the University of Maryland. And she decided to make GBMC Hospital in Towson home. And I'm always just so curious about the route that led you here to northern Baltimore. So why GBMC?
I was sort of looking for jobs when I started my sleep fellowship, knowing that it was a one-year fellowship. I knew the background I was coming from and had a sense of how I wanted to practice going into my year of sleep training. So that was very helpful. Two former fellows from University of Maryland's Pulmonary Critical Care program are my partners in the pulmonary practice. And so one is Don Slack, and I was in touch with him, and he was very happy here. And so I inquired. They were looking for a position. Someone was retiring who had been here a long time, who did primarily sleep and pulmonary as well as critical care, but she kind of had her niche where I wanted my niche, which is in those pulmonary sleep overlap. Some pulmonologists don't really want to be involved with that part, and some sleep physicians don't want to be involved with that part, so it worked well for me. And I just fell in love with GBMC as soon as I came here for my first visit. It's just a wonderful institution, very supportive. They have their eye on the right ball, is how I feel like is the way to describe it.
Oh, that's awesome. I'm so glad that you are right out of training, but actually, when I read your notes, I thought you were very experienced until I met you. I'm like, oh, she's younger than I thought, because your notes are just so eloquently, beautifully. I mean, the detail. If you want somebody to honestly take great care of you, then Dr. Stephanie Wappel there on that side, she is the woman for you, because she does great. Excellent work, excellent attention to detail, and she'll help you to sleep better. And that has a lot of amazing, amazing benefits to it, including weight loss, mood improvement, migraine help. I could go on, but that is your job to do when you guys meet personally. So how does somebody get started with you? Do they have to come in, or can they do it through telemedicine?
So that's great. We've actually been doing a lot of telemedicine since COVID. We are doing, I'm not great at percentages, but maybe like 90%. I see a few patients in the office each week, but mostly video visits, and our schedules have been pretty full. My partners are doing the same. So yes, if they if they had a sleep study and want to talk about the results, or if they want to come in and do an evaluation first, then yes, they can call our office, make an appointment, and mostly video visits. If they really want to be seen in the office, we're happy to do that, though.
That's fantastic. So to get started, you can go to the GBMC website, or you can also go right and call directly yourself. It's 443-849-3901. Dr. Stephanie Wappel still is accepting new patients. You better get in quick to see her because she's gonna sell out her whole schedule there of patients lining up, because my patients are very satisfied with you. And I think that means a lot.
You.
And I specifically referred to you and to Rhea Bay and Caroline Moon. I think that you ladies do just an amazing job at the GBMC Sleep Center. There's no other place like it. It's great. It's a great collaboration. Thank you for everything. And if you're interested, if you have sleep apnea and you're watching and your BMI is greater than 35, you can go to BMI calculator to figure that out. You can also come and get started with GBMC weight loss, and you do that very simply by going to our website, gbmc.org/weight loss, and click on the big Get Started Now. Somebody from our office will receive it, review it, and schedule you for an initial consultation. And we are also all virtual. We're 100% virtual still, and we are accepting new patients for bariatric surgery. So change your life, and hopefully we'll get rid of your sleep apnea, which is a good thing because we're excited and rewarding to help our patients. So with that, again, thank you so much to Dr. Stephanie Wappel and the GBMC Sleep Center for being here. Thank you so much. It was fun. I learned a lot. Again, I'm going to be spending some time looking into this new technology that exists to better treat our patients. And I hope you enjoyed it too. If you're watching this, sleep apnea does not have to be a terrible thing to treat. So please seek it out. Don't be stubborn. Come and see us. We'll take great care of you. So on behalf of GBMC Health Partners, I am Betsy Dovec, and thank you for watching this edition of What's Up, Dr. Dovec, about sleep apnea and Dr. Stephanie Wappel. Thanks again.